Bismillah, wassalatu wassalamu ala rasulillah, amma ba'd. My name is Abdurrahman Naeem Shuman, Faculty of Medicine, Azhar University. I am happy to be here in conference online. I am RS. My title, Congenital Anomalies of Esophagus and Treatment. In the first, I will talk about the development of esophagus. The esophagus extends from the respiratory diverticulum to the fusiform dilatation of stomach, each up to 4th week, then elongates rapidly up to 7 weeks, due to the descent of hard that pushes the stomach down into the abdomen. At 5th week, the lining epithelium is 2 cell thick. After 6 weeks, it proliferates, occluding its lumen. It realizes during 8th week, lying with stratified epithelium. In this picture, this is the verticulum, respiratory diverticulum, and elongate descend from it esophagus to the dilatation of stomach. Okay. In the first, stomach in the thorax, and the esophagus is short, and the heart pushes the stomach to descend the abdomen, and esophagus elongate, and in the first, esophagus is columnar epithelium, and then change to stratified epithelium. Congenital anomalies of the esophagus. Number 1, esophagus atresia and trachoesophageal fistula. Classification: esophageal atresia and or trachoesophageal fistula have been classified anatomically into 5 different types as follows. Number 1, pure atresia of the esophagus. Number 2, esophageal atresia with proximal trachoesophageal fistula. Number 3, esophageal atresia with distal trachoesophageal fistula. Number 4, esophageal atresia with proximal and distal fistula. Number 5, H-type fistula. In this picture, this is the 4 type of the esophageal atresia. Type A, this is number 1, and type B, this is number 2. Type C, this is number 3. Type 4, this is number 4. And type E, this is number 5, H type. Associated anomalies. Approximately half of the babies with esophageal atresia have other associated congenital malformation. An example: cardiac malformations. Cardiac malformation occur up to 28% of the patients. The most common cardiac anomalies are patent ductus arteriosus, ventricular septal defect, atrial septal defect, and right aortic arch. And also anomalies of the musculoskeletal system include hemivertebra, rib vein formation, and limb anomalies. Association with anomalies or malformation of the vertebra, anal, cardiac, tracheal, esophageal, renal, and limb organs. Bacteria have been observed in the 10% of the patients with esophageal atresia. Also, other anomalies associated with esophageal atresia include pulmonary hypoplasia, pulmonary sequestration, congenital diaphragmatic hernia, tracheal atresia, and chromosomal anomalies. Diagnosis and clinical findings. During gestation, the diagnosis of esophageal atresia usually can be made using fetal ultrasound. Almost all patients with esophageal atresia, and up to 60% of patients with atresia and trachoesophageal fistula, have polyhydramnios. Polyhydramnios, this is abnormal amount, abnormal type of amniotic fluid around the baby in the uterus. Okay, we use fetal ultrasound to need polyhydramnios. In this picture, there is polyhydramnios around the baby in the uterus by ultrasound. In the knee, excessive drooling is often the first symptoms. If feeding are attempted, the baby often chokes, regurgitates, and becomes cyanotic. Overflow of pharyngeal secretions into the trachea results in easy breathing, and respiratory distress is progressive. If mechanical ventilation is necessary, a lung complication is poor. Massive abdominal distension resulting in gastric rupture may occur due to free passage of air through the fistula into the stomach. This is clinical picture. Clinical picture, the first symptoms is excessive drooling and maybe chokes, regurgitates, and become cyanotic. Okay, and easy breathing and respiratory distress is progressive. Okay, and maybe abdominal distension resulting in gastric rupture due to passage of air through the fistula in the stomach. Okay, diagnosis of esophageal atresia is confirmed by inability to pass a firm oral or nasal tube in the stomach. We use oral or nasal tube. This tube is firm into the stomach. Is inability to pass this tube in the stomach, and perform radiograph to confirm the position of the tube. Also perform a complete physical examination because to assess cardiopulmonary status. This is very important, and to seek other congenital anomalies. In this picture shows esophageal atresia without fistula. This is type A. And frontal radiograph shows radiovacuum tube curling into the upper esophageal pouch aroused. No air present in the gastrointestinal tract. Why? Because there is no distal fistula. In this picture, the esophageal atresia with lower fistula, type C. Frontal radiograph catheter is seen collide within the upper esophageal pouch. Aroused. Air is also present in the gastrointestinal tract, indicating communication between the lower esophageal segment and the respiratory tree. The bowel dilatation is the result of an imperforate anus associated with esophageal atresia. And in this picture, this is H type E, tract of esophageal fistula without atresia, type E. Esophagogram show a fistula arising from anterior portion of the esophagus, letter E, this is esophagus, and passing cipher to the posterior portion of the trachea, letter T. Okay, management or treatment. The goal of treatment is to surgically restore esophageal continuity as soon as the baby can tolerate the procedure. If respiratory status is inadequate, or if further investigation is required to assess for other congenital anomalies, surgery may be delayed for a few days postpartum. Literature review by Kerr examined common long-term problems in the patients over age 10 years who had previously undergone esophageal atresia repair. Rates based on board estimated prevalence were as follows. Dysphagia and gastroesophageal reflux disease without histological esophagitis, gastroesophageal reflux disease with histological esophagitis, and with an recurrent respiratory tract infection, and physical diagnosed asthma and present cough and bad esophagus, compared with the general population, 4 times the rate of the occurrence in adults and 26 times the rate in children. Tracheoesophageal fistula without atresia. In this picture, tracheoesophageal fistula, each type of tracheoesophageal fistula. Each type is the type E. Diagnosis and clinical findings. Patients usually present in the neonatal period. Presentation symptoms can range from coughing and choking spells, preceded by feeding, to abdominal distension due to passage of air from the fistula, to recurrent and severe pneumonias. They often are unresponsive to antibiotics. Once the diagnosis is suspected, barium swallow with sinuradiography. Sinuradiography is recommended, but bronchoscopy remains the investigation of choice to confirm diagnosis. Most H-type fistula are above the clavicle and can be approached through the cervical incision. Intrathorax fistula requires thoracotomy for adequate access. Once identified fistula is divided and overseen. Pre-placement of a Fogarty catheter through the fistula by tracheoscopy facilitates intraoperative localization of the fistula and minimizes the risk of recurrent laryngeal nerve damage. This is treatment. Endoscopic obliteration of the fistula has been attempted with various techniques, such as tissue adhesive, electrocautery, and sclerosants. A 2006 study of 192 patients with tracheoesophageal fistula concludes the fistula that have not closed after 2 endoscopic attempts aren't suitable for further endoscopic treatment. Therefore, an external operation should be recommended. Esophageal atresia without fistula. Approximately 5 to 8% of the patient with esophageal anomaly have esophageal atresia without fistulas. Fistulas connection to the trachea. Why? Due to the long gap between upper and lower pouches. Surgical correction of the deformity usually cannot be performed during the first few days of life. In this picture, this chest histograph shows esophageal atresia without tracheoesophageal fistula. Diagnosis and clinical findings. During intrauterine life, patients have polyhydramnios, and the diagnosis can be suspected with intrauterine ultrasound. Why? Due to the absence of the stomach bubble. In the neonatal period, infants usually present with excessive drooling and scaphoid abdomen. Radiologic finds pathogenomic of pure esophageal atresia include dilated upper pouch and abscess of air below the diaphragm. In 2009, Hammond at Revine reviewed esophageal atresia cases without fistula. The most common associated anomalies were cardiac, 19%, followed by renal 16%, vertebral 17%, and anorectal in 7% of cases. The initial esophageal gap averaged 5 vertebral bodies. Treatment: continuous suction of the upper pouch and feeding gastrostomy constitute initial treatment. The patient then is followed closely with contrast radiographs until primary esophagus repair can be performed. Usually at an age of 2 to 3 months, if the gap between the proximal and distal segment of the esophagus is less than 2 vertebral bodies, the defect can be repaired with attention-free primary anastomosis. If after an age of 3 months the gap is still excessive, however, the esophagus can be reconstructed using gastric or conic graft. Also, another technique consists of secreting cervical esophagostomy with traction on the distal end. The upper esophagus is elongated gradually by repeatedly mobilizing it and placing the esophagostomy lower on the anterior chest wall until a primary anastomosis can be performed.